Hello everyone. Today we will discuss about chronic myeloid leukemia, or we can say chronic myelogenous leukemia or chronic granulocytosis leukemia, one of the same thing. So, what are myeloid cells? Myeloid cells are immature WBCs, which gonna mature into their respective WBCs or the neutrophils, basophils, or eosinophils. And what is leukemia? Leukemia is the cancer, like we all know, cancer of white blood cells. And where our white blood cells are made in the bone marrow. So this is cancer of bone marrow, right? Now let's move forward. Like we all know, we have 46 chromosomes in our body, or we can say 23 pairs of chromosomes. We have 1 to 23 chromosomes and their respective copies. So what happens in CML is there is chromosome number 9 and there is chromosome number 22, right? So we have ABL gene over the chromosome number 9 and we have BCR gene over the chromosome number 22. BCR gene is break cluster receptor gene. So in CML there is reciprocal translocation of ABL gene over the chromosome number 22 which have BCR gene. So what does it form? It forms BCR able gene complex or BCR able gene fusion gene product, right? We see there is chromosome number 9, gene goes from here to all over here, and this is reciprocal translocation. And one point to note here is also that BCR gene is a proto-oncogene. A lot of you would know that oncogene is a cancer causing gene. So proto-oncogene will turn into a oncogene, cancer causing gene. And BCR able fusion gene product that is formed, we also name it as Philadelphia chromosome. Like Philadelphia chromosome is also present in ALL, acute lymphoblastic leukemia, but in ALL it has the worst prognosis. In CML it has pretty much good prognosis. So this is the BCR-ABL gene complex. Now let's move forward. So clinical features in CML. How does the patient present in the hospital? All patients present to a doctor. First of all, we should note here is that patient will have non-specific symptoms, like it won't uh, give the diagnosis. So we have fatigue, weight loss, night sweats, right? And these are insidious. These symptoms are insidious. Other symptoms we can have is splenomegaly, or we can have hepatomegaly, or we can have enlarged lymph nodes, right? And these are painless. One point to note here is whatever causing pain will be infection. Any enlargement which causes pain would be infection, and an enlargement which is painless will be cancer, of course. And another thing to note here is that as the spleen grows in size, this infarction also occurs. Why? Because the blood supply is limited. Like the normal blood supply is for the normal spleen, but when the spleen grows in size, there is the area which won't get the enough blood supply, so it will infarct. And how do we hear it through the stethoscope? We will hear it as a friction drum. Okay, now, so moving forward, we have different phases of CML. So most of the patients are diagnosed in this phase. We have three phases: chronic phase, accelerated phase, and blast phase. So patient comes with their non-specific symptoms like fever, malaise, right? And you will order the different blood test, and you will make the diagnosis by another further test of CML. Like so, most of the patients are diagnosed here. In this, we have blast, like myeloblast percentage is less than 10%, and as the severity of the CML increases, the phase increases, and number of blast cells also increases. and which have in blast cells we have more than 20% of blast cells, or we can also call it as blast crisis, and it is very difficult to manage in this phase, difficult to manage. And another thing to note here is that almost half of patients progress in this fashion, like from chronic phase to accelerated phase to blast phase. But another 50% will progress directly from chronic phase and enters into the blast phase. This is entering into blast phase is very deadly. And even in the blast phase, we have development of acute leukemia. 70% will be of AML origin, myeloid origin, and 30% will be of lymphocytic origin. 30% will develop into ALL, which have worst prognosis. Now let's see how to diagnose this patient. First of all, when a patient comes to you, what do we order? A routine blood test. In blood tests, we have increased levels of TLC, total leukocyte. We can also order for absolute leukocyte count. We have increased number of neutrophils, basophils, eosinophils also are increased, and immature WBCs are increased. And we have also increased level of serum B12, and lab score is also increased. What is lab score? Lab score is leukocyte alkaline phosphatase. And sorry, lab scores were decreased because immature WBCs are more. Lab score is the score that determines the activity of neutrophils. So as the immature WBCs are more, so lab scores will decrease. Now let's see the peripheral blood smear of the CML patient. See, you can you can appreciate that it is basophil, right? And these are the myelocytes, myeloblasts. These are myelocytes. This peripheral blood smear basically shows different stages of WBCs. These are myelocytes, these are myeloblasts, and these are neutrophils, if you can appreciate. So, so peripheral blood smear will show different stages of immature WBCs. And, and we can always, for confirmation, we order for bone marrow biopsy. In bone marrow biopsy, what do we see? Of course, the hypercellular bone marrow, due to mutation, it will cause increased proliferation of cells. All the immature WBCs, we have increased reticulin count. We can also see blue histocytes, and we can also see pseudogaussious cells. And why do we call it pseudogaussious cells? Because it appears like gaussious cells. Like this is a gaussious cell. It does not have any cytoplasmic granules or ferritin. Ferritin staining is also not present. So these things we see in a bone marrow biopsy. Now, but it is not a best confirmatory diagnosis. Best confirmatory diagnosis we have this technique. What is it called? FISH technique. Fluorescent in situ hybridization. So what do we do in this FISH technique? Consider that we hybridize the gene with a colorful dye. ठीक है? See, consider this Z1 as BCR gene, right? And consider this green one, if you can appreciate well, ABL gene. So what happens in CML? Yeah, there is translocation of BCR gene over to the ABL gene. So there is ABL BCR ABL fusion product. So consider that this gene will translocation to this ABL gene. So it will come in close proximity, no? So what fish technique show is you that this is the BCR ABL fusion gene product, and you can see that yellowish tinge. It is because of the green and mixture of green color and the red color dye, right? You can also see it here also, right here. This is the fish technique to confirm the diagnosis of CML. So you have this is most confirmatory, or we can say best confirmatory. Now moving forward, how do we manage? We discussed about that BCR-able fusion gene product. It will form tyrosine kinase, right? And tyrosine kinase will increase proliferation of cells and decrease apoptosis. So of course, we can manage it by giving tyrosine kinase inhibitor like imatinib. This is targeted drug therapy. So that's all about chronic myeloid leukemia, or we can say chronic myelogenous leukemia, chronic granulocytic leukemia. I hope you like it. Thank